Good morning, everyone, and welcome to today's webinar, Fertility Tips for the OBGYN, presented by Dr. Riwa Sabbagh from Boston IVF. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you by Harvard around mid-summer. Now, without further ado, I would like to introduce today's speaker. Dr. Riwa Sabbagh graduated from the American University of Beirut with a major in biology and later completed her medical degree in American University of Beirut. Dr. Sabbagh completed her 4-year residency in obstetrics and gynecology at Baylor College of Medicine in Houston, Texas. She then completed her 3-year fellowship at Boston IVF and Beth Israel Deaconess Medical Center. Her current research interests include human embryo characterization, fertility preservation, and optimizing management of patients with thin endometrial lining. She has presented her work at several national conferences, including the American Society of Reproductive Medicine, the American College of Medical Genetics, and the Society for Reproductive Investigation. Dr. Sabbagh is fluent in Arabic and French and proficient in Spanish, which has helped her interact and communicate with patients from various backgrounds. Dr. Sabbagh specializes in all facets of fertility treatments and family building care. We encourage you to submit questions to Dr. Sabbagh during using the question section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the question and answer session at the end of today's presentation. All right, we're going to get started. I'm going to pass it over to Dr. Sabbagh.
All right, thank you, Alyssa, for the introduction. And welcome, everyone. Thank you for joining me, probably during your lunch hour, to hear about some fertility tips. So I have no disclosures for today. The objectives of my talk, I'd like to review the diagnosis and prevalence of infertility, review how to approach a patient about their fertility, review different factors that can affect fertility. I'd then like to review evidence-based options for management of infertility in your office. Then hear a quick overview of evidence-based options for management of patients with unexplained infertility. We'll then review when to refer a patient to REI, and finally discuss how to best prepare your patient to see an REI. All right, I'd like to start my talk by kind of going over some, percentages and probabilities of pregnancy in your normal fertile couple. And so for a patient that has regular menses and they have regular intercourse in any given month, they have about a 20% chance of pregnancy per month. And that's what this graph here shows. So even in a patient that's in their 20s, they have about a 25% chance of conceiving per month. That's their cycle fecundability. So it's kind of lower than what a lot of people expect. I have a lot of patients that are kind of surprised by this number. So it's only 25% chance per month. And if you do the math, it's about an 85% chance of, getting pregnant by 1 year. And if those that didn't get pregnant by 1 year continue to try, it's about a 90% chance by 2 years. So those that don't fall in this category and don't get pregnant meet diagnostic criteria for what we call infertility. And so what infertility is, and I'm sure you all know this, it's defined as not being able to conceive after 1 year or longer of unprotected intercourse. And the guidelines do recommend evaluating and considering treating women that are 35 or older if they've been having 6 months or more of unprotected intercourse. And we'll go into a little bit more details about that later. This diagnosis of infertility doesn't require ovulation monitoring. It doesn't require that a couple has intercourse every 1 to 2 days. And it can still be diagnosed even if a couple has a miscarriage, an ectopic pregnancy, or a biochemical pregnancy within that time frame. Now, in terms of the prevalence of infertility, so this was the National Health Statistics Report in the CDC in April of 2024. The data was collected between 2015 and 2019, and they surveyed over 11,000 women between the ages of 15 and 49. And what they found was 13.4% of women had impaired fecundity, and 8.5% of married women had infertility. And this probability was increased from the prior report in 2016, where it was 6.1%. So these are not insignificant numbers. So you're bound to see somebody in your clinic that has infertility. Which brings me to my first tip, given that it's not an uncommon diagnosis. It's really important to approach the topic of fertility with your patient. So any patient encounter with a non-pregnant women or men, and I know you'll be seeing the women with reproductive potential, is an opportunity to counsel them about wellness and healthy habits to optimize their reproductive outcomes. And this next bullet point was taken out of the ACOG committee opinion on the well woman visit, and it states that a key component of a well woman visit for any reproductive aged woman is the development and discussion of a reproductive life plan to ensure that medical testing and treatments provided are aligned with her current and future plans. And so this is not limited to just pre-pregnancy counseling and talking to them about contraception, but also should include an infertility assessment. There was a cross-sectional survey that was emailed by ACOG to about 5,000 ACOG fellows relating to counseling patients on reproductive aging and fertility preservation. This was in 2018. 748 responders completed this survey. And, excuse me, 82.8% and 74.8% agreed that conversations relating to reproductive aging and fertility preservation, respectively, should take place. But only 27.6% stated that they frequently counsel patients on these topics. So not as high as it should be. And the reasons that were most frequently noted for barriers towards this type of counseling was mainly limited time and limited knowledge. And so this brings me to tip number 2. Counsel your patient on factors that can affect their fertility. So talk to them about different things that they can do to kind of optimize their natural fertility. So I'm going to talk a little bit about these factors. So we have modifiable factors and non-modifiable factors. For the non-modifiable factors, the biggest one is age. So we know that there is a relationship between female age and fertility. We know that as women get older, it's harder to get pregnant. Their fertility declines, and that's kind of what we see here, where the percent of maximum fertility is at its highest in your 20s and mid to late, even early 30s, and then it starts to decline and reaches a low around 40 to 44. And this is mirrored by a rise in the miscarriage rate. And the main reason for this is aneuploidy rates. So as we get older, the risk of having an embryo that's chromosomally abnormal or aneuploid is much higher. But even at the young age of, in your even in your 20s, it's not a 0% chance of aneuploidy. It's about 20 to 30%. So not an insignificant number. And then it continues to rise. And at 44, it's a 90% chance of chromosomal aneuploidy. Wanted to briefly touch on male age and fertility, even though you are seeing the female partner in the couple, but it takes 2 to have a baby. And so male age is not something we should completely overlook. So this was a review that was published in 2001 in Fertility and Sterility. And they kind of looked at the effects of male age on semen quality and fertility. And what they found was increasing male age was associated with abnormalities in sperm parameters. So decrease in semen volume, a decrease in the percent of normal sperm and in sperm motility, no real effect on sperm concentration. But a lot of these studies in this review didn't really control for female partner age, so that's a big flaw. So it's difficult to draw definitive conclusions. But among the studies that did control for female partner age, there were 2 that compared fertility between men that were under 30 versus those that were over 50. And there was a decrease in pregnancy rates, about 23 to 38%. So not an insignificant number, even though it's for men over 50. In terms of modifiable factors, these are definitely factors that could be brought up and patients could make some changes in their lifestyle. And so the ones listed here are the ones I'm going to talk about. So first, in terms of timing and frequency of intercourse. So the fertile window is defined as the 6-day interval that ends on the day of ovulation. So there was a study that looked at 221 women that were attempting pregnancy. They followed them and kept track of the days they had intercourse and collected urine samples to analyze when they ovulated. And conception only occurred when intercourse occurred in the 6-day window that ended on the day of ovulation. And what the investigators confirmed was that the greatest chance of pregnancy was when intercourse occurred beginning 2 days prior to ovulation. And no pregnancy was achieved when intercourse took place after ovulation or only after ovulation. And so this is what you can see in this graph over here, where the peak probability of pregnancy is in this window and mainly at the 2 days prior to ovulation. In terms of frequency, so the optimal frequency is really defined based on the couple's preferences. There aren't really specific recommendations in terms of frequency because it can cause unnecessary stress in a couple that's already stressed about trying to get pregnant. And so we don't really give any specific recommendations from a frequency standpoint. And intercourse more frequently than every 1 to 2 days isn't associated with lower fecundity, which is a misconception because a lot of patients think that maybe there's reduction in sperm quality with more frequent intercourse, but really no differences in their chances of having a baby. And really, they should not be advised to limit the frequency of intercourse when trying to achieve a pregnancy. So in terms of different methods that can be used to, find out when your fertile window is, or what we call fertility awareness methods. So the calendar method, that's a popular one. It's based on the length of the menstrual cycle. And so like we talked about, this fertile window is set as the day of ovulation and the 5 days prior. So a lot of patients like to use the apps on their phone, which is a really popular way of tracking things. But the major pitfall of this type of method is that it doesn't account for cycle variability. You set your cycle length a certain day, and then it'll be the same every single month, which, we know cycles can vary month to month sometimes. The next one is the ovulation predictor kit, or the OPK, which is very popular. And this is when patients monitor their urinary LH excretion and they detect that mid-cycle LH surge. It's available over the counter at any pharmacy. And ovulation will occur usually within 2 days after a positive result with the OPK. And use of an OPK has been shown to decrease the time to pregnancy. Cervical mucus monitoring is another way. It's an inexpensive way to predict ovulation. And the probability of conception is at its highest when the mucus is slippery and clear, and the volume reaches its peak within 2 to 3 days before ovulation. And this way of monitoring has been shown to predict the day-specific probability of conception as well, or even better than basal body temperature monitoring or urinary LH monitoring. And I was surprised that a lot of patients actually use this method. And then last but not least, basal body temperature monitoring has been shown to correlate with serum LH levels, but its major downside is that it does have a high false negative rate of over 20%. Next, from a modifiable factor standpoint, is diet. So diet is a very popular question that we get. What can I do? What can I eat? Anything I can do to improve my fertility. So there isn't really any data to suggest that any particular diet can impact fertility. But fertility rates are decreased in women at extremes of body weight, and primarily this is because of an ovulatory dysfunction that occurs. Women that are underweight are at risk for hypothalamic dysfunction that can affect their ovulation, and those that are overweight or obese can also have ovulatory dysfunction with or without the presence of PCOS. The Nurses' Health Study 2 is a study that looked at the impact of a fertility diet, which is a diet that favors monounsaturated fats, more vegetables, higher in dairy, multivitamins, and irons from plant sources. And they found a lower risk of infertility in women that had ovulatory dysfunction that were on this diet, but no difference in live birth rates in people undergoing assisted reproduction. And I think the biggest thing that we look at a lot in a lot of the studies in the IVF world is the birth rate, because there could be a lot of parameters that could change, but really the main goal is what is the live birth rate? What is their chances of actually having a baby and taking that baby home? The Mediterranean diet is another one that was studied. It's a diet that's high in fruits and vegetables, olive oil, fish, poultry, and the Dutch diet that's also high intakes of whole grains, monounsaturated oils, vegetables, fruits, etc. Those diets were associated with higher live birth rates after IVF in some studies, but the data was conflicting because other studies didn't really show a difference. And then studies that looked at the effect of low processed diets that had higher intakes of fruits and vegetables and whole grains really didn't find any association with improved IVF outcomes. And so to sum this all up, there's really mixed and inconclusive data on the effects of diet on natural fertility and on assisted reproductive outcomes. And so adhering to a healthy diet in general and having a normal or maintaining a normal BMI between 20 to 25 is what we recommend for someone's overall health. But really having specific recommendations on a certain diet, there's really no data to back that up. In terms of other lifestyle factors, so smoking. Smoking is a big one that we counsel about. It is a confirmed reproductive toxin. It is definitely associated with decreased fertility. It is toxic to the ovaries, and it's found that women that smoke can go through menopause at 1 to 4 years earlier than women that do not smoke. I also put this here just so you have it in the back of your mind that it can also negatively impact sperm quality. And since, male factor of fertility is definitely one of the big etiologies of infertility in general. So we also like to counsel our patients on its effects on sperm quality. Caffeine is a big one that we get asked about. So the daily intake of high doses of caffeine, so that's over 5 cups of coffee or over 500 milligrams per day, has been associated with reduced fertility. And there is some data to show that more than 2 to 3 cups of coffee, so 200 to 300 milligrams per day, is associated with a higher rate of miscarriage. So we tend to counsel on 1 to 2 cups of coffee, but caffeine hasn't been shown to have any effect on sperm quality. Alcohol, there is no evidence to date, at least linking mild to moderate consumption of alcohol with infertility, but chronic overconsumption, so over 2 drinks per day, can lead to a decrease in ovarian reserve and in fecundability. And from a male standpoint, chronic alcohol consumption has been associated with lower semen parameters as well. And then marijuana hasn't been shown to have any effect on female fertility, but has been associated with decreased sperm counts. So one of the only parameters listed here that has an effect on male but not females. And then last but not least, from a modifiable factor standpoint is stress. So stress has really been studied very extensively. Some studies do find an association between stress and fertility, but others don't show an impact on IVF outcomes. And I always think about it as what came first, the chicken or the egg, because we know that stress can cause infertility, but infertility can also cause stress. So it's really hard to delineate which one came first. But just so you know that there has been some studies kind of linking the two. Now that we've talked about, how to approach a patient about their fertility and the different tips to optimize their natural fertility, it's important to know when to evaluate a patient for infertility. And so, this is not a talk about the evaluation of infertility or different testing, but I do want to kind of bring up some points. So when to evaluate a patient. So really 12 months or more of unprotected intercourse, if they're under 35, they warrant an evaluation. And 6 months or more of unprotected intercourse if they're over 35 or greater. And you can consider immediate evaluation if they're 40 or older. And this evaluation is done irrespective of how long they've been trying to conceive, if a couple or if a patient has irregular cycles, if they have any risk factors for tubal disease, if there's a suspicion for male factor infertility, or if they have a history of sexual dysfunction. So if they have any of these, you really don't have to wait the 12 or 6 month mark before you evaluate them. In terms of the evaluation, so there is an ACOG committee opinion on the infertility workup for the women's health specialist. Their table 1 kind of summarizes all the tests, and so I listed them here just so they're more clear. But at a minimum, it is recommended to get testing on cycle day 3. It's always says cycle day 3, but it can be done anywhere between day 2 to day 4. We get an estradiol and an FSH. Check their ovarian reserve via an AMH or the anti-Müllerian hormone. Confirmation of ovulatory cycles. So if they have irregular cycles, likely ovulatory, but some ways to confirm that would be to use the ovulation predictor kits and see if they do have that LH surge. Checking luteal phase progesterone on day 21. Less helpful tools are the cervical mucus monitoring and the basal body temperature. Checking for tubal patency is an important one in your evaluation, and then a semen analysis. And so after you've tested your patient and evaluated them, it's really important to know which patient may benefit from treatment in your office and how should you treat them. So in short, who to treat, basically it's your anovulatory patient, so your patient with PCOS. In terms of the workup, in brief, I mean, you've done the workup. We just talked about it, the estradiol, the FSH, an HCG, checking a TSH and a prolactin to look for other causes of anovulation, an androgen panel, especially if you're suspecting PCOS, and then a transvaginal ultrasound, also looking for polycystic appearing ovaries on the ultrasound. And once you've diagnosed them with anovulation, the main method to kind of induce ovulation is what we call ovulation induction. And this is just different. And I wanted to just bring this point really quickly. It's different from what we call ovarian stimulation. So when you're giving these agents to someone who's anovulatory, it's called ovulation induction, as opposed to when you give them to someone who's ovulatory. You know, it's common to call it ovulation induction, but it's called ovarian stimulation. And so ovulatory disorders can be identified in 18 to 25% of infertile women. And it's usually a favorable prognosis because, you know, by inducing their ovulation, you know, it's a highly effective method, especially if that's the only reason for their infertility. There are 4 classifications for ovulation disorders. You have your hypogonadotropic hypogonadal anovulation or hypothalamic amenorrhea patients. The normogonadal normoestrogenic anovulation, so that's mainly your PCOS group. The hypergonadotropic hypogonadal anovulation are your patients with POI, premature ovarian insufficiency, and then your hyperprolactinemic anovulation are your patients with hyperprolactin or hyperprolactinemia. And so I'm going to focus on the normogonadal normoestrogenic anovulation. So the different treatment options that you have available, I've listed them here. These are the different agents that we used for ovulation induction, but you'll probably be using the clomiphene citrate or letrozole. But just so you know, gonadotropins or recombinant FSH is available as an ovulation induction agent, and we sometimes do use that in our PCOS or anovulatory patients. So for clomiphene citrate, so it's a selective estrogen receptor modulator. It competes with your endogenous estrogen for binding to the estrogen receptor. And by doing that, it causes a reduction in the negative feedback. And so it stimulates your pituitary gonadotropin release, which will drive more ovarian follicular development. It was the traditional drug of choice for ovulation induction in PCOS or anovulatory infertile women, and that's no longer the case, and we'll discuss that shortly. So currently what we use it for, it's most frequently used to stimulate multifollicular development in ovulatory women that have unexplained infertility, and that's used in combination with an intrauterine insemination, which we'll touch upon shortly as well. So just so you know, it used to be used as the main drug of choice for PCOS, but now we actually use it for ovarian stimulation in women that do ovulate. Its treatment regimen, so it's given for 5 days, starting at anywhere cycle day 3 or 5. The dosing is somewhere between 50 or 100 milligrams. We have gone up to 150 milligrams. Sometimes it is weight dependent. The LH surge is usually expected 5 to 12 days after treatment ends. You can monitor for the LH surge via the basal body temperature monitoring, ovulation predictor kits, or ultrasound. And there is no clear advantage of one method over the other. And usually you would time intercourse once the LH surge is detected. The outcomes, so among anovulatory women who do respond to Clomid, the overall cycle fecundability is about 15%. So it's not terribly high, but just, keep in mind that this is a group of patients that has been having trouble to conceive, without any additional agent. So their chance of conception per month is less than 5%. So we are increasing their chances by adding this agent. So it increases to about 15%. The cumulative pregnancy rate reaches 70 to 75% over 6 cycles of treatment. The side effects associated with Clomid are usually transient hot flushes, headaches, breast tenderness, pelvic pain, and nausea. The main risk we discuss is the risk of a multiple pregnancy, and there's about a 7 to 10% chance of that happening. And a common question we get asked is any relationship with cancer, and really there's no causal relationship that was found between any ovulation-inducing drug and cancer. Letrozole is the second ovulation induction agent that's available, and letrozole is an aromatase inhibitor. What aromatase does is it catalyzes the rate-limiting step in estrogen production. And so by giving an inhibitor, you're blocking this estrogen production, which will lead to an increase in gonadotropin secretion. And currently, it is the first line for ovulation induction in women with PCOS because of the higher live birth rates that were found compared to Clomid. And I'll bring up the study that showed this in a second. In terms of the treatment regimen, it is also given for 5 days, cycle day 3 or 5. The dosing is 2.55 or 7.5 milligrams. Then you would monitor for the LH surge and then time intercourse once that surge is detected. In terms of its outcomes, there are higher ovulation rates, higher pregnancy rates, and higher live birth rates in letrozole compared to Clomid in patients with PCOS. The side effects tend to be more favorable than Clomid. Most people don't have side effects at all, but some reported effects are fatigue, headache, and cramps. The risk of a multiple pregnancy is 3 to 7%, so still there, but lower than Clomid. And so this is the study that I'm referring to, which is the study that was published in the New England Journal in 2014, looking at Clomid versus letrozole for infertility in patients with PCOS. And what they found was improved ovulatory response, an increase in conception, an increase in live birth rate in letrozole compared to Clomid, with the percentages listed here. There was a lower twin pregnancy rate, but this was not a significant result. So now that you've identified your agent, you've identified your patient, and you want to treat them. So a lot of these patients, don't have normal periods or don't have periods at all. And so in terms of using progesterone withdrawal, there really isn't any benefit in doing that, except if you're trying to prevent endometrial hyperplasia, or let's say the lining of their uterus is incredibly thick and you just want to have them bleed. That's fine to use the progesterone, but for any other indication, not really necessary. So you can do random labs and check an FSH, an estradiol, a progesterone, and an HCG, ideally with a transvaginal ultrasound to kind of determine where the patient is in their cycle. And if the estradiol is normal and if their progesterone is low, you can just start them. They don't need to have a bleed. They can start letrozole. I just put here in as example, it's 5 milligrams per day for 5 days. And then you would ask them to monitor with ovulation predictor kits once per day, 1 to 2 days after the completion of letrozole. You would then measure their progesterone on cycle day 21 to confirm ovulation. And then once the patient has ovulated, if they don't get pregnant, we usually expect menses 12 to 14 days later. And you can repeat this letrozole for 5 consecutive days in the early follicular phase. So you can just keep repeating it month after month. So I know we said, can use the OPK, but it's not mandatory. And we do know that, so if it is used, usually ovulation will happen 24 hours after the peak, but we know that in some patients with PCOS, it's not a very reliable tool, so you may or may not choose to use it. Oocytes usually survive 12 to 24 hours. Once released, the sperm can survive up to 5 days. So I think this is just an important point that having intercourse earlier is better because the sperm needs to be there waiting for the egg as opposed to the other way around, just because of the survival timing. And so intercourse usually every 1 to 3 days from day 10 to 16 in a normal cycle. And then once you've established that a specific dose worked and that they ovulate with that dose, you don't really need to repeat, keep checking the progesterone on day 21 with every cycle. So if you've chosen a dose, let's say 5 mg, and they do ovulate, you don't have to keep checking for ovulation because you know that dose worked. This is just a little calendar that I make because I like to show patients because it makes it easier for them to kind of know what's going on. And so usually they'll call with their period and then they start taking the letrozole, let's say, and then either you encourage them to have intercourse day 10 to 16, but if they are using an ovulation predictor kits, they would start roughly around day 10. And for somebody with 28-day cycles, you would expect, a positive surge on day 12, so an ovulation on day 14. You check a progesterone on day 21 and then a pregnancy test on day 28. Now, what about the use of metformin? So this was a study in the New England Journal in 2007 that looked at three groups of patients that took Clomid only, patients that took metformin only, and then a combination therapy of Clomid and metformin, and they looked at their live birth rates. And what they found was the group that took metformin only had significantly lower live birth rates than the group that took Clomid only or the combination group. And there was no statistically significant difference in the combination between the combination group and the Clomid group only. Now, just keep in mind, I know it says Clomid and we were talking about Letrozole, but this is a study that was in 2007, back when Clomid was the first-line agent for these patients with PCOS. And so just based on this, there isn't really any sufficient evidence to support the use of metformin in patients with PCOS just for the sole purposes of fertility, and so in the absence of any impaired glucose tolerance. What about other ovulatory disorders? We talked about all the other categories. So for hypothalamic amenorrhea, this is usually a diagnosis of exclusion. And so in young patients that have normal ovarian reserve, it could be reasonable to refer them to a nutritionist or a therapist to kind of help them and maybe get them to start ovulating again. And for your hypoprolactinemic patients, definitely an MRI could be warranted to rule out any sort of prolactinoma, and it is reasonable to treat them with cabergoline or bromocriptine in a young patient to help restore their HPO function and help them maybe start ovulating again. So, we talked about who to treat. So my tip number 5 is identify which patient may not be a good candidate for treatment in your office, so who not to treat. So should you be treating patients with unexplained infertility in your office? So this is a study that looked at 580 women that were randomized to 3 arms across 4 hospitals over 6 months. And the 3 arms were using Clomid with timed intercourse, so just Clomid, or just an IUI, so no Clomid, but just an IUI, versus expected management. And what they found was there was no difference in the Clomid-only group versus the expectant management. And there was also no difference in the IUI-only group versus expectant management. So really, in your patients with unexplained infertility, using just Clomid is no better than not using it at all, or doing just an intrauterine insemination is no better than not doing anything at all. This next study looked at stimulated IUIs. So these are patients that got Clomid or Letrozole and had an IUI versus expectant management. And there is a significant difference in the live birth rates in the group that had the stimulated IUI compared to just expectant management. So the combination of the two was definitely better for patients with unexplained infertility. Next, I kind of wanted to just briefly talk about 2 big RCTs and big trials that we always quote and frequently referred to, referenced, and these are both of them are trials that were published by members of our group. The first one is the FAST trial, and it's an RCT that was looking at the value of a gonadotropin IUI, so FSH IUI, which is another one of the agents that we talked about that we can use. And the couples were randomized to either the conventional or the accelerated arm. And in the conventional arm, they underwent 3 cycles of Clomid IUI, then 3 cycles of FSH IUI, and then IVF, as opposed to the accelerated group that underwent 3 Clomid IUIs and then straight to IVF without doing the FSH IUI. And their main outcome was looking at the time it took to establish a pregnancy that led to a live birth, and also looking at cost effectiveness. The mean age of the patient population was 33. And so what their results were was a shorter time to pregnancy and a higher cumulative pregnancy rate at 12 months in the accelerated group compared to the conventional group. And it was about $10,000 cheaper to go through the accelerated arm versus the conventional one. And so in summary, going straight to IVF after doing Clomid IUI is more cost effective and time effective. So no need to go through the FSH IUI in between. And the next study, which may be more interesting for you guys, but is the 40 trial, which is looking at the management of unexplained infertility in women at the end of their reproductive potential, so in an older population. And these couples were randomized to either 2 cycles of Clomid IUI, then IVF, or 2 cycles of gonadotropin IUI, then IVF, or directly to IVF. And their main outcome was pregnancy rates, number of cycles, and then the time to pregnancy. The mean age of the patient population in this study was 40, ranging anywhere between 38 and 42. And their results showed that there was a significantly different pregnancy rates between these three groups, with a higher pregnancy rate in the IVF group. And the time to pregnancy was definitely shorter in the group that went straight to IVF compared to the ones that underwent the IUI cycles first. And so in summary, for older women, going straight to IVF is the most successful strategy without going through Clomid IUI or FSH IUI before. ASRM has a guideline for the treatment of unexplained infertility. And in summary, what they recommend for patients with unexplained infertility, you can do Clomid IUI, you can do Letrozole IUI, and this would be one IUI done at 36 hours after the LH surge. And usually they recommend 3 to 4 cycles total. What they do not recommend for couples with unexplained infertility is a natural cycle IUI or Clomid or Letrozole without the IUI. And so to kind of summarize this section, who would benefit from treatment by their OBGYN? So mainly it is your anovulatory PCOS patient. That's the big group. Potentially patients with hyperprolactinemia or functional hypothalamic amenorrhea, like we talked about, to kind of get them to start ovulating again. But those that would not benefit are mainly the patients that have unexplained infertility. And I put male factor infertility down there because, again, it is a big chunk of the etiology of infertility that we see. And so this brings me to my last tip for today, is to know when to refer a patient to REI. So this is a list that I just put together, and it is by no means includes everything, but refer a patient to REI that is of advanced reproductive age, because like we just talked about with the 40 trial, they benefit from going straight to IVF as opposed to going through other modalities first. Patients with unexplained infertility, also like we just talked about, because they potentially would need more aggressive treatment in the sense that they would need an IUI or IVF. Patients that you've tried Clomid or Letrozole in your PCOS patients and they failed 3 to 4 cycles. Patients with tubal factor infertility, so you did your HSG, something looks wrong, their tubes, they're either not patent or something looks abnormal, they could benefit from referral. Patients that have male factor infertility, so if their semen analysis parameters are abnormal. patients with hypogonadotropic hypogonadism. So the reason I put this here was some of these patients, if they don't get to ovulate after you've tried other options, is they usually would need gonadotropins to help them get to ovulation. And so they would potentially benefit from an FSH, IUI, or IVF for treatment. Patients with premature ovarian insufficiency, and depending where they are, could benefit from donor egg. Patients with recurrent pregnancy loss, patients that are planned to undergo gonadotoxic therapy, you can refer them to talk about different options for fertility preservation. Same-sex couple or a single individual that's looking to build a family. There are transgender individuals that are interested in current or future fertility options. So this is just a list of all the possibilities. And so my last slide is kind of a summary slide, but we'll summarize on how to prepare your patient to see an REI. And so discuss their reproductive goals. So any patient that comes in with, that is of reproductive age, talk to them about what goals they have, identify if they have any modifiable or non-modifiable risk factors, and talk to them about them, especially the modifiable ones, to see if there's anything you can do to help them optimize their natural fertility. If you've identified patients that are, that do meet diagnostic criteria for infertility and are having trouble, you can obtain an infertility workup. And then consider ovulation induction, mainly with letrozole for your patients that have PCOS. And then last but not least, identify patients that need to be referred to REI, and then we'd be happy to see them. These are references, some of the references from my talk today, and thank you all for listening, and I'm happy to take any questions.
Thank you, Dr. Sabbagh. We're now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. Dr. Sabbagh, the first question is, how would you counsel a healthy female patient under 35 years old who comes in after 6 months of trying to conceive and asking for a fertility workup? It happens all the time.
So it happens in our world as well all the time, where they come in less than where you expect them to try for a year. And I don't think it's unreasonable to start the workup earlier. It takes a while to get to treatment. And so usually we're dictated a lot by insurance. So insurance may or may not cover their diagnostic testing. But if that is not an issue, I would definitely I don't think it's unreasonable to start the workup, because the majority, though we say, 85% will get pregnant within a year, the majority will get pregnant within 6 months. So you're already filtering out a whole chunk of patients by, waiting those 6 months. So I don't think it's unreasonable to get the testing first, but I would be very frank with them and counsel them that you probably will get pregnant if you try for 6 more months. So if they're willing to, that's fine. But if they really want to get the testing going, and especially if they have any risk factors for anything, I don't think it's unreasonable to get the testing done even at the 6-month mark.
Thank you. The next question is, for patients with PCOS, if they don't get pregnant after multiple rounds of letrozole, can you try Clomid next? I mostly work with a population that cannot afford REI.
Yeah, so I don't think there is a study, there isn't a study that looked at letrozole, then Clomid, and looked at pregnancy rates in PCOS patients. So I don't have like a response from like an evidence-based standpoint, but from a timing standpoint, usually we say 3 to 4 cycles of letrozole before moving on. And when we say moving on, we mean, either adding on the IUI or moving towards IVF. But I definitely understand, and I know that sometimes cost is a big issue. And so if the reason why they're not responding is that they're not ovulating, then I think it's totally reasonable to try the Clomid to see if that will get them to ovulate, because some people just respond to one agent and not the other. But if they are ovulating on letrozole and you are getting a positive response from an ovulation standpoint, there really isn't any benefit in switching agents. Other than they can't do anything else. But if they are ovulating on one agent, I would just stick with that agent.
Thank you. The next question is, how do you know what dose to start for Clomid and letrozole?
So for Clomid, it's usually weight-based. There isn't, or I don't know on the top of my head exactly what BMI to start, but usually our patients with normal BMIs from a Clomid standpoint, we would start with 50. If they're overweight or obese, we would do 100. For letrozole, The thought is to start at the lowest possible dose, but I will tell you that I usually give them 5 milligrams, and I don't do the 2.5 because I found that not everybody responds to the 2.5. But usually you would start with the lowest possible dose that gets them to ovulate and then stick to that. It is not weight based for the letrozole, but like I said, I usually tend to prefer starting with 5 milligrams. I've seen that most people are successful with that dose.
The next question is, if a patient has tubal factor, example, unilateral or bilateral hydrosalpinx, should we consider surgical management before referring?
Another great question. So for hydrosalpinx, it kind of depends on the degree and if it's like distal versus the entire tube that's dilated. But we do have evidence showing that people that have a hydrosalpinx can have lower implantation rates and pregnancy rates. And so I don't think it's unreasonable to recommend to remove the tube even before referring them because we will be counseling them on removal and that just kind of delays things. And so if they're kind of waiting to see us, removing the tube is not unreasonable, but I definitely would caution you on patients that have bilateral tubal disease because they just need to be very, very aware that the hydrosalpinx definitely does have an impact, but we don't know if they can get pregnant while the tube is dilated. It could happen. And so unless they are committed to proceeding with IVF, removing both tubes, and it will commit them to that so they can get pregnant spontaneously. So that's definitely just a conversation to have with them. But definitely something to consider, especially if they have unilateral hydrosalpinx and it's really prominent, to remove it before referring them.
Thanks. The next question is, for a patient who has diagnosed PCOS, do you need to do the tubal patency evaluation prior to starting letrozole?
So for completion's sake, we like to do, at least from our standpoint, we do end up checking for everything because a lot of patients surprisingly do end up having several factors that's causing their infertility. But if they don't have any risk factors, let's say they don't have a history of prior STIs or PID or anything that could be increasing their risk of having tubal disease, just doing the workup and starting the letrozole is not wrong, and I think is totally reasonable as well.
Thank you. The last question for now is, what lifestyle modifications do you recommend for sperm health? What environmental factors are you telling people to avoid, aside from the obvious smoking, drinking, etc.? Should we be worried about microplastics?
So from a sperm quality standpoint, like you mentioned, we definitely, talk about the toxins like smoking, drinking, and all the stuff that we talked about in the talk today. We also always talk to them about like recent illnesses or fevers because we know that can affect sperm quality at least within the 3 months because we know that sperm, reproduces itself and regenerates every 3 months. And so if they've had a recent illness and they've had a semen analysis that doesn't look great, I would repeat it in 3 months. Other things that we talk about are things like frequent sauna use or hot tub use or things like that, because we know that a higher temperature, when a higher scrotal temperature or testicular temperature can affect sperm quality. And I never asked that question before I became an REI, but I surprisingly have a lot of patients that tell me they have a hot tub at home and use it pretty frequently. So something to think about. From a plastic standpoint, I at least haven't come across any studies that linked the use of like plastics or phthalates or things like that with sperm quality, but I'd have to look at that more deeply. I don't know. I've looked at it from an ovarian standpoint, but not as much sperm.
That was our last question. Thank you, Dr. Sabbagh, and thank you everyone for attending today's webinar, Fertility Tips for the OBGYN. If you have any other questions, you can contact myself, Alyssa Cooper, at ecooper@bostonivf.com. Once you leave today's webinar, you'll receive a survey on the presentation. We would appreciate if you could complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF and Dr. Sabbagh, thank you for joining us and enjoy the rest of your day. Thank you, Dr. Sabbagh.